Okay, so without further ado, I'm going to hand things over to Michael. Thanks a lot, Michael.
Awesome. Thanks so much, Ian. Thanks everybody for giving up your time on a Tuesday morning / afternoon, depending on what part you're joining from. We're going to talk about pain. It's a very personal topic for me, and you'll see why. And really talking about understanding and managing pain in patients with intellectual disabilities. Very, very important topic. So little education that you're actually going to see on this topic. So hopefully we'll be able to pull you along and show you some examples of what I've actually built up from practice, and I'll explain why this is such a personal topic to me. So here we go. First off, my disclosures, I work with a variety. I develop continuing education. So give you some background. I'm a pharmacist by training. I left full-time pharmacy practice, and now I work as basically an educator. I educate clinicians around the world. This is my primary gig. Pain is something that I focus on. I do a lot of work within chronic pain, as well as a lot of work that we publish on the use of cannabis for the management of chronic pain as well. Here are my disclosures. And what we're going to cover over the next hour, really looking at about how do you assess a pain in a patient with intellectual disabilities or cognitive impairment, discuss non-drug and drug treatments for patients with both acute pain and chronic pain, patients that you see regular within your practice as well, and determine when a person with pain should be referred for additional support. It's unbelievable. The people that you guys see is such a diverse group. So if you look at different clinical practices, you guys have in the patients or in the residents that you see within your settings, they're diverse, all different in terms of communications and cultures, all have unique abilities and all have unique challenges. And the reason why this topic is so important to me is it's actually, my daughter actually has relatively severe ASD and an intellectual delay. She was diagnosed at 4 years of age. This is us sitting at the beach. This is at a Wyndham Park that we had last summer. She's really, from the standpoint, she's verbal from for needs, but I'm sure a lot of you have seen residents like her, but not anything else. She will say yes, no, good. She loves route speech. She's memorized many episodes of Dora the Explorer and SpongeBob. She can actually quote those bases, but really the communication has always been a challenge. What terrifies both my wife and I is if anything major happens. So if she has an acute injury or condition, she had dental surgery 3 weeks ago. We knew that she was in pain, but she doesn't know how to actually convey it. When she's in chronic pain or in acute pain, she just shuts down. So she actually just falls asleep and she's just so not like her normal self. And she really can't communicate. So there's these behaviors that we know, we can actually tell are something that's unique and different for her. That's how we can end up telling that something is actually wrong. And what scares us is that what ends up happening, we know that she's going to end up having to be supported by individuals like you that are going to have to be our place as her caregiver. And that really, it's how do we work to this one? That's one of the reasons why I like to do these type of talks, is to be able to support you guys to be able to help out individuals like my daughter Danielle. Okay, so let's talk about pain. There's different types of pain, but really a definition. And I'm going to apologize ahead for the AI images. I love them. I put them all into these ones, but we're going to talk about pain itself. We're going to talk about acute pain and chronic pain. Pain is just an unpleasant sensory or emotional experience. It's associated with actual or potential tissue damage or described in terms of such damage. So some key things that are there. There's an emotional component that's associated with it. So it's not just about that it's actually a sensory issue. You stub your toe, you feel the pain that's there, but there's some emotion that's attached to it. There's something to remember. And what's key here also is that it's actual or potential tissue damage. So what we see in chronic pain a lot of times is that there is no tissue damage anymore. The tissue is healed, but the patient is still feeling pain that's associated with it. Pain is actually a protective force. The reason why we have pain is to notify the body that something is going to cause damage. Thus, we need to move away from it. You put your hand on a hot stove, you feel the heat, it burns, you pull away from that standpoint. Otherwise, it will lead to damage. And there are patients or individuals that actually have low pain sensation, no pain sensation that have been born. And most of these people don't reach it until their 20s because it has that protective effect. Acute pain for most people is temporary, serves as a warning. So if something is wrong, that something may cause damage or some part of the body. When we heal, that acute pain goes away. So think about if you have a sprained ankle, you end up working out, your muscles are sore, they heal up, it goes away. Chronic pain is a little bit different. Pain that exists despite complete tissue healing or pain that has no identifiable causes. So these are patients that are in pain all the time. Greater than 3 months is usually the cutoff for most of these ones, and it could be associated with no identifiable cause. So what caused that pain? We don't know. Low back pain a lot of times is the issue associated with that, or from a chronic disease. If patients have osteoarthritis, rheumatoid arthritis, fibromyalgia, they could be causing that type of pain that they're experiencing. So why do we want to focus on pain? And the numbers are terrifying. And what's here is like it's the number one reason for emergency department visits. And I'm sure you've seen with residents as well. 70% of the people that present with an emergency room have some type of pain. It's the vast majority of those individuals that are there. 20% of individuals live with chronic pain. That includes children and teens. So what we would consider young and healthier individuals, those patients still end up having pain. It's 1 in 5 individuals that are there. And then if you're lucky enough to, when you hit that magical mark of 65 years of age and older, if you have that mark, it's about 1 in 3 live with some type of chronic pain. So it's a significant burden on all of us that are there as well. So what about pain in patients with intellectual and developmental disabilities, similar to my daughter Danielle? Well, there's so little pain research, and we see this across the board with and in autism. We see this across with other developmental disabilities that they just don't do research within this individual group, and it's very difficult to do research within these groups. There is absolutely no reason to believe that pain occurs less often in people with intellectual and developmental disabilities or IDD. There was a thought process is that people with autism don't feel pain or people with developmental disabilities don't feel pain. It's just they express it differently. And I'm sure you've seen this with residents or patients is that all of a sudden that, what would normally be a normal behavior for them is just different. They don't cry out. They don't yell and they scream. It just should be different. Again, my daughter, what happens with her, she shuts down. It's a very different response than what we would see if one of my other children ended up having pain, where they would come to me and say, listen, it's sore here. What can I do about it? Some studies that have been done within these groups, especially with high functioning patients with intellectual and development disabilities, they find about 40% to 60% of this group end up having chronic pain, which is a little bit higher than what we typically see. And others have said they're not as sensitive to pain, so they don't feel pain differently. But what we looked at is there was one study that did with individuals or adults with high functioning autism. And what they ended up doing is they took their hand and they put it into warm water. And what they wanted to do is see how long they could hold it before they felt pain. So these were individuals that could comprehend it. And what they found with that group versus a neurotypical group is that the patients that had high functioning autism actually felt the pain earlier than individuals that actually were neurotypical. So it really is a disbelief, or it just doesn't happen where patients are with these intellectual and development disabilities don't feel pain. They do, and a lot of times they're more sensitive to it. The biggest issue that I see in this group is it's vastly undertreated, vastly poorly managed within this group. And that's really where you guys can come in and actually help to support these individuals. You live with them, you see these individuals every day. These are the people that you can end up supporting to end up helping you process. So, what are the sources of pain in people with intellectual and developmental disabilities or IDD? And you know what? Chronic pain is common in people with all of these disorders, and it affects daily activity and participation levels. We see it. Other sources, again, you take care of some really vulnerable individuals, but feeding tubes, dislocated hips, pressure sores from being in wheelchairs or in bed for a long period of time, injuries from assisted devices, so walkers, wheelchairs, can all lead to some aspects of chronic pain. And then some of the conditions that they end up having, they have an increase in tone and and spasticity that can end up causing pain, spasms, weakness, or any type of loss of function that could be causing pain as well. So where do you fit in? I mentioned the important role that you guys have. You can look at where, as a parent, I can't see when my daughter moves into assisted facilities, is you're going to be me. You're going to be my caregiver for my daughter. And these are the things that you're going to be looking out for. Is any changes in behavior that you don't typically end up seeing with those individuals? How do you assess that overall pain? What are the things that you're really going to be able to identify to look for those? When and how to manage pain? What do we need to do to be able to help these individuals? Helping others determine what works and what doesn't work for a patient. We'll talk about dosage formulations of how you can administer different things that can make a difference. And we talk about, I'll give you an idea. My daughter can't take anything orally in a tablet. She'll just throw it back up at us. Even chewable, she'll usually throw it back up. Tylenol quick dissolves came out for pediatrics, and we gave her a higher dose of that, whereas a sachet, we just mixed in a bit of water and it went down perfectly for her. So it's really working with those individuals and what their needs are to be able to address and manage their individual. And then we have to be able to know when to refer. So what's typical pain, when it should be referred to that patient, and then refer to an emergency room or the family physician, nurse practitioner, and then monitoring response to overall treatment. So what are we going to do? We're going to take a look at two patient cases or two individual clients that you may see. One of them is acute and one is chronic pain. And we're going to spend more time on acute, and then we'll discuss what this means for chronic pain as well. So it's Jim and Elaine. So Jim, he's 35-year-old. He's living with autism and he's completely nonverbal. He's currently taking lamotrigine 100 milligrams twice daily. quite common for patients with autism and many intellectual and developmental disabilities to require medications for epilepsy. He woke today and he was clearly agitated. He refused to eat breakfast, which was really unusual for him. He keeps grabbing at his back and his ankle. He's never had back issues in the past, but it commonly injures his ankle. And this could be for anything from, it could be more unsteady. He's injured it once before, doing those activities before, and then further irritated. So standard of care for when we manage chronic pain is we use a brief pain inventory. And I put QR codes. I'm going to make the slides available to anyone who wants them. So that can all be through Alicia, and she'll jump on at the end. But a brief pain inventory has been around for a long period of time. It was originally set up for cancer pain. This is what we use for a neurotypical patient to actually identify their pain. And it's really on a scale from 1 to 10. So just to let you know, is that there's no measures for pain. So many of you that are on this one, just because we know the demographics that I showed you, some of you are experiencing chronic pain. I can't tell you based on laboratory tests, an x-ray, or any other component what your pain you're perceiving. So the only way we can do that is self-reporting. So self-reporting for patients on a scale from 0 to 10, 0 being no pain whatsoever, 10 being the worst pain you've ever felt or the worst pain imaginable. What is your current pain level? What is your pain at worst? What is your best? What is your pain on average? And how well does your treatment actually help to manage your pain? And based on that, we can have an idea. And just to give an idea how weird pain is that we can look at osteoarthritis is a great example. So this is basically the wear and tear condition that we see on knees. You can have two patients that come in. One patient that will rate their pain on a level of 10. You do an x-ray of their knee, and there's really no damage that's there, but their pain is at a 10. You can take another individual who say their pain is a 3 or 4. You can take an x-ray of their knee, and it's completely destroyed, bone on bone, causing tremendous amount of irritation. So pain is a unique perception of what that individual can have. So just because they may have no damage doesn't mean they have no pain. And we have to accept what that patient is self-reporting. What the thing is that when we look at the treatment wise, it's individualized. So, typically what we end up seeing a 6 to 7 is and 8, 9, 10 or more that severe type pain, whereas more than mild to moderate is at 5 or below. But what we can see is that when we look at the numbers and we follow up with the same tool, we use the previous results that the patient answered with his current results or his or her current results to be able to adjust that overall treatment. So it gives us an idea how well we're doing for the patient as it's moving. So that's what we would do for a neurotypical patient. But again, you have individuals that just can't communicate on this level. So how do you do this when you're asking them on a scale from 1 to 10 or 0 to 10? There's no way my daughter would be able to respond to any of this component at all. And neither would our patient Jim that's here as well. So there's a couple of tools that have come out, and this is one that is designed for non-communicating adult pain checklist. So this was actually one that was designed for people that were in a merge or within hospital that you can actually assess. There's a lot here. Yeah, there's a lot on this thing, but it gives you an idea of what they're looking for. So a poor pain assessment is likely a reason for undertreatment. So how do we assess better? So the thing here is we're looking for vocal reactions, emotional reactions, facial expressions, body language, any type of protective reaction. They're grabbing at an ankle for this patient, grabbing at their back, and then physiological reaction, changing in facial color or any of those other components that are there. What's unique about you and your group that is so different from, say, a physician that's sitting at a merge or any other health professionals is just seeing one of your residents for the first time is that you know these people. So you know the clients, you know what's typical. Are they crying? Do they cry? Are they scream? Is that a typical? So for my daughter, screaming and occasionally getting loud is actually a kind of common response for her. That's just normal in terms of part of her stims. But that may not be typical for somebody like Jim. So if that's actually happening, so what is typical, what is not? You know if something seems wrong just based on the reaction that you have, and you can estimate the severity based on the overall behaviors. So if things have gone off the rails, you are the one that can actually provide that component to just let them know that something is not right. Again, if I was to present to an individual like at hospital and just looking at my daughter who's been in pain, she's not anymore, but it was in pain that 2 weeks, and I just say, well, what she does is she's lying down in bed. Well, they'll say to me, Mike, she's not in that much pain, but I know that's not typical for her. And I know that's actually a very common response to pain management for her. She just shuts down. Thus, I knew that she was in a lot of pain and discomfort. So it just gives you an idea of how you can interpret what these people are feeling. So that's one tool. There's quite a bit that's on this tool, but you can see that it's pretty straightforward in what they're looking for. And it just gives you an idea that even if you don't use the formal exam, you can have an idea of what to look for. The furrowed eyebrows, the turning down their mouth, they're not smiling, the movement of the lips and tongues, like all of those things that you can end up seeing. One that is unique, and again, I'm not trying to say that people with IDD will end up being a patient with advanced dementia, but this tool is actually not bad from the standpoint because, again, for a non-communicative individual, we have an idea of what's here. So then they look at breathing, negative vocalization, facial expression, body language, and consolability. And based on that overall scale, you can end up looking at what that person would be. So 7 to 10 on the scale would be moderate to severe pain, 4 to 6 is moderate pain, and then mild pain is 1 to 3. This is actually a fast tool to actually be able to do. And you will actually, again, because you know your residents so well, your patients so well, this is a way that you can actually look at it. And that breathing, is a labored breathing, are they moaning and groaning? Are they seem facial grimacing? Like all of those things will give you an idea of how to rate it. And it can be just an effective tool to be able to assess that individual with that is non-communicative with pain as well. So if we look at Jim, Jim is saying he's crying, he's verbalizing, he's whining. He's cranky, he's irritable and agitated. So this emotional component. His facial expression, he's squinting his eyes, he's not smiling, which is not typical for Jim. His body language, he's moving less, he wants to lie down. He's having a protection reaction, as you can see in the image. He's touching his back, he's flinching when anyone comes close to his back. And remember, all of these things are far from perfect. And just to let you know, pain assessment in general for anyone there, none of these tools are perfect. They don't work 100% of the time. They do help, but again, you have to go with a lot of times your gut feeling of what's there. And it's really, you know, what's normal and what isn't for your clients. Is really helping to vocalize that to anyone that's managing them. And that can help for the course of action that's there for that individual. Things that I would want to watch out for. These are what are called potential red flags. And these are red flags for patients that are presenting for pain. And again, I'm not going to go through everything here, but what we're looking for is things that may be associated with a more severe condition than something that is acute, like a low back pain or a sprained ankle, where we can manage within the home with just some simple measures. These are things that could be more serious that are there. So things that we were looking for is if there's any neurological deficits where the patient is actually not being able to move their arms, if the patient is actually getting tingling from that standpoint, if they're able to communicate that, if they've had fever, chills that are associated with it, they just look unwell, very, very unwell. These are individuals who want to get there. History of physical trauma, even in some of the older adults that you may end up having. So these are patients 65 years of age and older. If they've fallen, what would be normal for, say, a resident that's 25 to 30 years old, if that client falls, probably going to be fine. If you end up having this older adult that's there that are sitting in their 60s and 70s that fall, this patient could be at higher risk of a fracture just due to osteoporosis. Malignancy, what we look for malignancy are patients that have had unexplained weight loss that's associated with it and pain that just doesn't start until after the age of 50. So we may want to evaluate that a little bit more. Vascular, this acute monoarthritis, you can get pulsating pain, very difficult to actually identify. Again, this would be somebody who you think would have a headache. You treat them and things are just not getting any better. Those are individuals you want to see. And again, unexplained weight loss, night sweats, fever, all indicate this patient should really be seen as quickly as possible. We usually, for that case, to identify what's going on. What are low back pain? And we have 30 people that are watching today, right? So really, what you can tell you is that if you live long enough, almost all of us are going to have back pain in our lifetime. It's 84% today. And again, up to 25% of us or 23% of us will having it at any one given time. The great thing about low or acute low back pain is that it's usually self-limiting. If you do nothing at all, it usually resolves within 2 to 6 weeks. The problem is it's incredibly painful, and if anybody's had it, it affects everything in your life, from getting up in the morning to sleeping to moving to eating to trying to work. Everything, it's impacted from that component. And only a very small portion of these patients will go on to develop chronic low back pain. So the majority of people that develop this condition, it will improve on its own. If we do nothing at all, it will just seem to get better. Then for our patient here, we have sprains and strains. I just want to give you a highlight from them. So a sprain is actually a stretch and or a tear in a ligament. It's classified by its severity. So how severe is that sprain that's on it? And the locations usually ankles, knees, wrists, and thumbs. And what we see for these patients, we'll get pain around the joint, tenderness, swelling, bruising, pain on weight bearing, and a decrease in overall function. And sometimes there can be some joint instability for more severe injuries. Strain is when we're actually tearing muscle fibers in a tendon. And again, it's classified based on the individual severity of how much is torn. Common in the foot, hamstrings, or in the back. And we see where these patients get muscle pain, cramping, spasms, weakness, inflammation, and some bruising for those individuals that are there. So depending on the location, it can be either a sprain or strain. The good news is most of the time, if it's mild, they're treated very, very similar. One question that I get from healthcare professionals is, Mike, what could be a fracture? Like this person rolled over on their ankle. Could it actually be a fracture? So just to give you some ideas of what to look for is what were they doing when they developed this injury? Did it just roll over? It's probably not going to be a fracture for the most of these individuals. Was there a snap or a pop at the time of the injury? When did it occur? Fractures, usually it's immediate pain when that patient occurs. So when of the pain, if it's right away, we usually end up seeing from a fracture. The one thing is that there's no swelling, it's unlikely a fracture. The swelling can develop within minutes to an hour. Tenderness, all injuries will cause pain, but the tenderness becomes really localized. So it's really in that area. It could be a fracture that's there. And sometimes the symptoms, really high severity in terms of the overall pain versus what the injury was. Those are times that I'm like thinking, maybe we should be referring those individuals that are there. So how do we treat it? Well, low back pain for the majority of people is we treat it with non-drug, is the preferred method that we have. And regardless if we use medications associated with it, we should always be promoting non-drug methods. The most important thing you can tell anyone, and this would improve your residents, your clients that you see within your work setting or family members, the most important thing they can do is keeping active. The worst thing they can do is actually bed rest. Bed rest is associated with actually worsening of pain and increased risk of chronicity. So higher risk of it becoming chronic pain if the patient becomes inactive or just lies in bed. So we want to slowly return to the normal activities as quickly as possible. So as they feel more comfortable, we want to promote that basis. Again, most patients, if you do nothing at all, nothing, within 2 to 6 weeks, there'll be a treatment recovery. Everything about this is actually to make them feel better, more comfortable. Hot or cold paths can end up helping for the individual. And again, as I mentioned, avoid bed rest. One of the key challenge here is actually looking at patients with IDD, applying on a cold press, because some individuals with these conditions are actually very sensitive to cold or heat on their body, that becomes even more anxiety causing. So the amount of pain relief or the amount of that they may feel from that is actually going to make them worse because they're more anxious about it. So for my example, to use a heat pad on my daughter, not a good thing. It would not go over very well, cause her more anxious than any of the benefits that we would actually get from that individual treatment option. So again, it's classified. So for her, if she was to have this, we would just try to keep her active as much as possible. Other one is looking at its price, and I named it. It's corny, but it's the Price is Right. But it's really some of these acute injuries, like an injury to this patient ends up having an ankle. We want to protect it from further injury. We want to look at rest and avoid any activity for the first 48 hours. So for that ankle, we want to make sure. So back, we want to keep them active. Ankle, we want to rest them for that first 48 to 72 hours. Ice, the timing of ice is actually really important for this basis. It's only for about 15 to 20 minutes every 2 to 3 hours. You delay for you during the first 48 to 72 hours, and not to be applied when the person is sleeping. Because again, there's one of the things that a lot of people say, well, what as cold as possible, but what you can end up doing is actually causing more damage to the topical surface of the skin. So again, it's just to help for the swelling and help for some of the discomfort. Compression is one of the things we'd recommend for it. Compression is just elastic tubing. Think of a tensor bandage. Want to be snug, but not overly tight. It's really to help to control some of the swelling that's there, and it can actually support the area that's basically. So if you wrap the ankle, it may end up helping. And then elevating. Elevating the interior area can actually support using a pillow. If they're actually sitting down from that standpoint, and that can end up helping, but not any length of time. So the key thing that you'll see with this one is this usually for the first 48 to 72 hours, as that person is actually starting to improve, we would start to reintroduce moving them again, trying to protect the overall area. And again, some of the challenges here is that compression for some of these individuals is just not going to happen. It's just not going to happen where you're going to be able to comfortably do this. So you may need to modify based on the resident clients that you serve. Again, every client is completely different. Some will like that basis, some will love ice packs, some will hate it. Some will love compression, some will hate it. So adjusting based on that individual. So it's very difficult to make blanket statements for the overall group. So for low back pain, what are the treatment options we have? The first line treatment options would be acetaminophen, which is Tylenol. And Tylenol, one of the things that we like about it, especially in some of the residents that you see or clients that you see, is they're medically complex. The safety of Tylenol is actually quite good, up to 4 grams per day. So that would be 2 extra strength up to 4 times a day of those individuals. That's a maximum dose. The key thing is make sure they do not go above that 4 grams per day. Side effects are very well tolerated. It's safe from pretty much every chronic disease. The primary concern is liver toxicity, but the advantage is that these residents have is that you're going to be the one that's supporting them to be able to actually administer those doses. So thus, very unlikely they're going to be over that 4 grams per day. NSAIDs or non-steroidal anti-inflammatory drugs. Think of your Advils of your world, your Aleve of the world. What these do is they reduce pain and inflammation. Ibuprofen is the brand name for is a generic name, drug name for Advil. It can be used for individuals. Diclofenac is a prescription-based product. Naproxen sodium is what's in Aleve. The issue with these drugs is that they work quite well. They actually work really well. If this was a healthy individual that was coming in, they can reduce the pain that's associated with it, can work really well to reducing inflammation, where Tylenol doesn't reduce inflammation and much, it really focuses on pain. The problem is they have a lot of drug interactions. None They have some drug interaction, but the main issue is going to be drug disease interactions. I'll cover those in a little bit further. But if the patient has a stomach issue that's associated with it, if they have a kidney issue, they have type 2 diabetes, they have cardiovascular, heart disease, any of those components, we're a little bit more careful about giving these drugs because they can cause fluid retention for those individuals and potential issues. Muscle relaxants have been used. Cyclobenzaprine, it's a drug that's brand name is Flexeril. It looks like a little house. Many of you may have seen a beige house that's associated with it. It has been used for this one, especially for low back pain. It can soften up those muscles. Methocarbamol is actually the drug that's within Robaxit, Robaxisol, and Robaxin. It actually softens up the muscles. The problem that we see in patients with IDD is that these drugs can cause sedation. So there can be some issues with confusion in those individual groups. So we just have to be a little bit more careful about using those drugs. This is a summary on Tylenol. Again, I'll provide this to anybody that's there. So they have their regular formulation with it's 325 milligrams per tablet. Then the extra strength is 500 milligrams. So the standard is usually 1 to 2 of the extra strength Tylenol every 4 to 6 hours, up to a maximum of 8 tablets per day. One of the things I want to highlight is the formulation is really important. The time release formulations of these drugs, and even some of the house brands of these products. So, there's a Life brand, there is a Walmart brand that is there that have time release formats. These are 1,300 milligrams, or they are 650 milligrams per tablet. So you would take 2 of these 3 times a day to get that maximum dose of 4 grams. So we have to be just careful in terms of what we're dosing. No dosage adjustments in older adults. So if they're over the age of 65, we can still give them up to 4 grams per day. No worry in patients with heart disease, stomach conditions, type 2 diabetes, kidney disease is generally fine. The issue with Tylenol or acetaminophen is that it's a primary cause of drug-induced liver damage right across the board. And most of the patients that have this one, or most individuals that have been reported, it is when they take over 4 grams per day. Remember, you're the caregiver, you're the one that's administering these drugs to these individuals. It's unlikely that that person is going to go over 4 grams per day. The vast majority of the cases that actually led to toxicity were intentional, so it's over 50% of those individuals. Risk increases if the patient has liver disease, if they're dehydrated. And the key thing I want to highlight here is antiepileptics. Antiepileptics are used in your patient, or anticonvulsants in your patient groups, higher than any other group. And the reason why is that antiepileptics or anticonvulsants can cause more of the breakdown of the metabolite that causes liver damage in patients that are taking it. Acutely, so patients only using for a couple of days, not usually a major concern. It's when people are using high dose for a long period of time that can be a potential issue. So if you're unsure, this is where your pharmacist can really end up helping and looking at those individual groups and how you want to end up managing those patients as well. And since the summary is here, so the key thing here is all anti-inflammatory drugs work well. So Advil and Aleve and all prescription anti-inflammatory drugs are all the same in terms of reducing pain and function. The issue is that we're all a little bit different. About 70 to 80% of us will respond to Advil. 20 to 30% will do nothing for us. So we can actually try. If patients aren't responding on Advil, we can move into Aleve or a prescription-based product, and they may do fine. Celecoxib is a coxib, so this would be Celebrex. It is actually very similar in terms of how well it works in comparison to ibuprofen. The advantage over coxibs is that what they do is they cause less stomach issue, but they can cause the same increase in blood pressure that we end up seeing with these drugs. Heart failure is an issue because it can cause fluid retention, more fluid in the body. It makes it more of a load on the heart, more load in the heart, more fluid in the lungs, harder for that person to breathe. Kidney issues, all anti-inflammatory drugs have kidney side effects. So if you know a patient has a kidney problem, we really want to be careful with these drugs in this patient population. And then chronic use of these anti-inflammatory drugs can lead to lesions in the body. And we know that a lot of people end up having ulcers associated with it. So we just have to be careful with this. If you know a patient is going to have to use it, one of your clients are going to be on it chronically, talk to your pharmacist, talk to the clinicians that are coming in. There are strategies that we can use to reduce that overall risk. Muscle relaxants we talked about as well. These ones can be used. They usually use short term. The biggest concern with them is that they can cause drowsiness and dizziness and clumsiness. That can be concerning for patients with IDD. And we always use them not on their own, but in combination with an anti-inflammatory or Tylenol. That's typically how we end up using them. If we are using them for a lot of individuals that are nighttime, because if we make them drowsy, they can just sleep at nighttime, and that can end up helping for the pain. So sleep can end up helping them recover. This is that just quick summary. Again, only use at nighttime. And as soon as with these ones, and I'll mention this a variety of times, with all pain medications generally, as soon as the individual starts to feel better, they're not in pain, we would discontinue or lower the dose. So we would taper the dose down. So if they're on Tylenol, we put them up on 4 grams a day. The pain is starting to improve. We reduce the dose and we can pull them off it. Great. If they have no pain, we don't need to give them medication. The same would apply for anti-inflammatories or anything else. Is usually the lowest possible dose that we need for the shortest possible time. So this is kind of the key consistent thing that we're thinking about. Lowest possible dose for the shortest possible time for any of these pain medications. Topical NSAIDs is an interesting one. So we have within Canada, we have a couple of them. Pennsaid is a prescription-based product. The over-the-counter one is Voltaren that many of you may have seen. They're kind of cool in the way that they end up working. So it's an anti-inflammatory drug, but it's not really going into the body. It's less than 5% of it actually gets in the body, but we're applying it directly to where we need it. So think about if you're using an inhaler. Why we like inhalers is that we give the drug and it only goes into the lungs, so it's a lower risk of side effects. If a patient has a sore knee or a sore elbow, we apply the drug directly onto that individual site, and that actually reduces that issue. And they have been found to work as well as something like Advil for soft tissue injuries. So if you actually have an injury where you end up having a sore knee or sore ankle, anything that's superficial, sore hand, it can actually help for that basis. And even for low back pain, it can help for any of those acute muscular type injuries. It does not work for anything deeper. So great for the hands. So use your joints here, right on the surface, knees right on the surface, ankle right on the surface, but hip will do nothing for that basis because you can think about it. It's not absorbing into that joint, thus is not actually working. Will not work for more of a deep-seated issue like a headache or as well. The key advantage of these ones, they're much safer than oral NSAIDs. They don't have the stomach issues that we see associated with it. And the only side effects that we typically end up seeing are just local skin reactions, some dry skin, itchiness that we would actually see from that basis. So generally well tolerated. The issue that we're going to see in your patient population, your clients that you guys have, is that it's not covered. So the cost of these ones can be an issue, but it's a safer way and it may end up helping to manage that pain. Talking about specific issues, it's not just about the drug, but it's also about the formulation. So I have found that most individuals that have intellectual and developmental disabilities, many of them have a hypersensitivity to the side effects associated with it. So sometimes even lower doses that we can end up using can still cause side effects, but be able to manage the pain. So we just have to be careful. The key thing here is there's lots of different formulations for these drugs. As I mentioned, the News Quick Dissolve, they're not designed for an adult. They're designed for a 6 to 11-year-old, but we can adjust the dose for an adult. And they worked incredibly well for my daughter to help to manage her pain over the last couple of weeks. It's a formulation that just came out this last year. Chewables are available, liquids are available, liquid capsules are available. You can customize a flavor, you can customize the drug. The key thing that I would advise you to is that if you're working with your clients, your residents, is once you find a formulation that they can get down. So say, for example, they love this junior Advil grape and they love it and it's no issue. Not only do you need to document that you actually gave them Advil or ibuprofen, you want to document the formulation. It was great. It was junior. It was a 100 milligram dose, and this is what ended up happening. And if it didn't work, document it until you find that individual one that's there. So the key thing is to make sure that it's dosed appropriately. The issue that we see with these chewables is they're actually designed for children, so you need to adjust the dosing different than what's on the packaging. And again, your pharmacist can really end up helping you with this as well. So the team at GreenShield can make a difference. Topicals, easier. You just rub them in. And for a lot of people, something like Voltaren would be a much easier formulation that you'd end up using. So what are we using for Jim? We're going to look at acetaminophen was there, topical or oral NSAIDs, non-drug methods are all going to help out. What you can do is from a staff perspective and for your client here, Jim, is really comfort them as much as you can. Jim, we're going to work on this one. You know what works for comforting. Every one of these adults or any one of these individuals have a different comfort level of how you can actually make them feel better about this component. He's not bothered by an S-pack, so you can put that on his ankle. He takes regular strength Tylenol on a consistent basis. So it could be the caplets or the tablets, has a standing order for PRN use, and you're going to follow up with his healthcare team if he's not responding in a few days. Okay, Elaine, much more complicated. We have a 58-year-old, severe individual disabilities due to meningitis as a teen, lots of issues, type 2 diabetes, high blood pressure, high cholesterol, diagnosed with osteoarthritis in their hip in the past, took acetaminophen when needed, standard drugs that we would typically end up using for a patient with diabetes and high cholesterol and high blood pressure. The team has noticed Elaine is walking slower and holding her hip, not behaving like her normal self, worsening pain in the morning, and it's impacting her daily activities. When asked what hurts, she just points to her right hip. Using the same thing that we talked about for acute pain. Vocal, she's wincing and crying out as she gets out of bed. She's emotional, very uncomfortable, not cooperative, especially in the morning. It's really hard to comfort her as well. Your facial expressions, again, you know your residents. This person looks uncomfortable in her face. Body language is very slow to get up in the morning. She's a protective reaction. She's occasionally touching her hip, not him. She's limping and favoring her hip. So there's no basis. So as we talked about right at the beginning, is thinking about patients with chronic pain and individuals with IDD. Oh, they don't have pain. Well, what we do know is that many of these patients do, or many of these individuals with intellectual developmental disabilities have chronic pain. And there's actually data showing that it may actually occur more common than in a neurotypical group. They require long-term management and, like acute pain, vastly undertreated. And I'm sure you've seen those as residents where they're in pain all the time and everybody is worried about how do you manage this effectively. All patients with chronic pain also are not static. So just like if you have a mother that ends up having, oh, Siri's talking to me. If you end up having a mother-in-law or mother that ends up having osteoarthritis of their hip, just like with this patient Elaine, it can get worse over time. So we have to remember that also happens in patients with IDD or individuals with that where it can get worse and we need to adjust the plan to actually help for this one. Again, this is where you have such a huge impact. I can't stress that enough. That you know your clients, you can see what those changes are and what's normal and what's not for these individuals. So when a person with chronic pain is not responding, so the key things that we should be thinking about, are we assessing the pain correctly? I've given you some of the tools to actually help for that process. So what are we looking for? How do we end up doing that? And that charts of those two assessment tools can really help for that basis. Is the right treatment goal for the patient? What are we trying to do? For most patients with chronic pain, just to let you know, it's almost impossible to get a person to be pain-free. We look for, if an ideal management is anybody who can get a 30% reduction in pain or improvement in function. So you think of a patient as saying, I have a pain scale on 10, I have the most pain that's imaginable. And if I get that patient down to 7, that's actually viewed as a success. So 30% reduction of pain would be actually typical. It's very difficult to get a patient to be pain-free. But one of the things we're focusing on is improvement in function. The person wasn't getting up and moving around, and now they're able to. That's usually viewed as a success in terms of overall treatment. What are changes that indicate they're not responding? So this again is, what are the visualization? Is that treatment working for this patient? Other symptoms that they could have, and what have other people in the team seen with this client? So it gives you an idea of what to look for as well. I apologize for my graphic design skills, but it gives you an idea of what to look for. You have an aged person, if they're an older adult, chronic conditions or current medications, what do you pick? So if it's an older adult, chronic conditions or current medications, you really go to acetaminophen or topical NSAIDs would be your primary basis. Those ones are unlikely to cause any problems with any of these issues based on the age, the chronic conditions, or the current medications. The others are, you can look at NSAIDs and other treatments, but it becomes a little bit more difficult. So if you're when in doubt, acetaminophen or Tylenol, topical NSAIDs are usually the way that we like to go for those ones. But if it doesn't work, or there's other issues that are there, you could consider NSAIDs or other treatments. And this is really when in doubt, this is where your pharmacy team can end up helping out as well. Drug interactions are common with anti-inflammatories. I just don't want to go through it. The one thing I want to highlight here is this one. There are drugs that actually increase drug levels with NSAIDs. The one thing is lithium, and that's higher within your patient population that you're going to end up seeing. And then these drugs, if anti-inflammatories, something like Advil, can cause a toxic level of lithium for some of those patients. Tylenol, I talked about epilepsy medication. The other things are going to be like tricycling antidepressants and that. These ones, patients on warfarin, complex medications, we have to be careful of bleeding risks when we end up giving them anti-inflammatory drugs. Hip-related pain like this, these are the guidelines that were published a few years ago, what you can end up treating. Like almost all pain, non-drug is usually the way we start, and we can add drug, but we still keep that non-drug. So patients are having hip pain, things that can end up helping short and long term. Any type of exercise would end up helping these ones. So cardiovascular, any type of resistant exercise. But if the patient has a sore hip, things to look for would be exercise bike where we're supporting their weight so they're not actually putting all that pressure on it, or water-based exercise can end up helping, which could be a challenge for some of your residents. Weight loss could end up helping to reduce it. And then the others are looking at Tylenol, which you discussed, acetaminophen, oral NSAIDs, ibuprofen, naproxen, diclofenac, and then we can use cortisone injections as well. So how do we take care of this patient? We have lots of options that can be used. She's used acetaminophen in the past. We're going to restart it to help with her pain. Not going to be any problems with her diabetes, not with her high blood pressure, high cholesterol. So if she's used it, we know what formulation works. We're going to help to use that pain. We're going to look at other options. If it doesn't work, we can end up looking to help for that basis. And we really, at this patient, chronic pain patient, worsening of symptoms, good idea to see your family physician or the physician that takes care of this individual to assess her overall hip to see if there's anything different on that basis. So what can you do tomorrow? So things that you can do, and I would implore you, as a call to action, as a parent of a person with IDD, is really looking at for monitoring for changes in behavior, looking at those components. What's different with these individuals that you can highlight? Again, this is a vastly undertreated group. So any of those spaces that you can end up helping with can change the life and trajectory for some of these patients. Living with chronic pain is miserable, affects their mental health, physical health, everything. If you can end up helping and supporting that one, it can make a difference. Look for the signs of chronic pain. So just what can be there, how they communicate it, what to look for. You need to work with your individuals to break that stereotype that people with IDD don't feel pain. That's just not consistent in the literature. We know that they have chronic pain just as much, and if anything, they may feel acute pain more intensely than individuals. It's just that they respond differently than other individuals as well. In patients with IDD, and all individuals, anybody here is presenting with chronic pain, non-drug methods are usually preferred, tailor on their abilities and pain levels. Simple treatment options. If you would have come back 15 years ago, we would be talking about all the prescription products that we end up having. There's been a real renaissance of going back to simple approaches of using Tylenol and anti-inflammatories for patients. They seem to work as well, seem to be safer for many of those individuals. And I would implore you to work with your team here at GreenShield Health to work with a pharmacist to look for the different options that are available. Here, I'm looking at 14 minutes. I'll take a quick look at my questions that are here, but I thought I would cover combination of oral. Okay, I'm doing okay on the questions. I'm going to go through some of the other ones because when we presented this one in, this was a little bit ago in Chatham, some of the questions that came up were looking at the prescription options that are there. So had some discussion about other pain medications. I think I'll take a few minutes to go through that and I'll answer any of the questions that come up. I'll stay a little bit later if I need to. So some of the questions that I get asked are like cortisone shots. When should they be used and when should they not be used in chronic pain? Cortisone shots are actually injected. If you're not familiar with it, we inject a steroid directly into the joint. So they can be used in the hands, into the knees, into the hip. What they do is that if you put a cortisone shot, and think of it as a massive amount of anti-inflammatory that's actually injected right into those areas. They work well. They work quickly for those patients. So, relief within 4 to 6 weeks, and that pain can last for up to 3 to 6 months. Many of these patients are completely pain-free after they have this done. The problem is that you can only inject them 3 to 4 times per year in the joint. Otherwise, we start to break down that individual joint. It doesn't work as well. And the joint can actually get in worse shape from that standpoint. From yours, one thing as caregivers is to think about if you have a person that has a cortisone shot in their knee or into their hand, you want to minimize joint activity for that one for 3 days after the injection. Otherwise, they can have quite a bit of pain in that area. So try to keep them a little bit immobilized from that standpoint. Cannabis is one thing that I've done a ton of work in over the years, and the use of it for chronic pain has actually increased. It's a very polarizing treatment across the board, but when we actually interview Canadians about it, one study found that about 97% of people that are using medical cannabis were using it for chronic pain. The other two are stress and anxiety or insomnia. And fundamentally, many patients with chronic pain have all three of these. So it's sometimes patients find that they get relief not only from their pain, their stress and insomnia. The issue with it is that we just don't have a lot of data. So I was on this guideline that we published, and it's actually been well cited. We brought a group of experts to how do we end up using it. And typically for most of the patients from chronic pain, we start off with CBD only. So CBD sensitive predominant products, usually in an oil-based format that we're administering for individuals, which would be the only way they'd be able to administer to residents as well. We don't want them smoking. We don't want them vaping that individual product. We slowly increase the dose until they get their pain relief or until we manage the symptoms. If they don't get that, after we get up to about 40 milligrams of CBD, we typically add THC, slow doses on that component. CBD is generally fine. And for some of your patients that are there, the concern that I would have is a little bit of drug interactions. You can check with your pharmacy team on that issue as well, but doesn't cause sedation, and it may end up helping for seizure frequency for some of those individuals, as well as helping for pain. Once we started adding THC, this can cause some sedation for some of these people. It can cause them to feel a little bit dopey. That can be a concern in patients with IDD, so we just have to be careful from that standpoint. But THC is used more for, it's what helps generally for sleep for individuals, but I have a lot of patients that will respond to CBD alone. In cannabis in this group, as I mentioned, THC can be a concern with anyone with cognitive impairment. It's not a major concern with CBD. The only concern I have with CBD are the potential for drug interactions that are there. Methods of administration, we talked about oils or other oral formulations. They have sublingual formats, they have oils, they have capsules that can be used. Smoking vaporization, especially in individuals with IDD, would not be recommended. The challenge is always about getting that right dose, finding the one that seems to work for those individuals. Once we find that, we typically stay on that drug. The one weird thing about this with cannabis in comparison to opioids is tolerance doesn't develop. So with opioids, and we'll talk about it in a few minutes, is that if you respond on it, what your body becomes tolerant to the pain effects, and you need to take more and more to get the same amount of pain relief. What's interesting about medical cannabis is that when we get them to a typical level, they actually stay at that level for a long period of time. It doesn't seem to be an issue. And I think it's because of the focus of CBD versus using THC. Tricyclic antidepressants. I'm as old as dirt. As you can look at me, I have no hair here. I have all gray in my beard. Tricyclic antidepressants were drugs that we used back when I was born to actually manage these conditions. So these are drugs like things that you may see within some of your clients are on, or amitriptyline, nortriptyline. These are drugs that are used to actually manage pain. They usually help for neuropathic pain. Neuropathic pain is unique from the standpoint is that we have pain signals that move up and down. So conditions that when the pain signal is transmitted up, where there's no damage, there could be a problem with the signaling pathways that are causing the issues. And what these drugs do is they seem to settle down those signaling pathways, so the perception of pain is less for those individuals. It helps for neuropathy. So patients that have diabetes, if they develop the nerves start to go in their feet, you may have seen this with some clients before, they start to get chronic pain within their feet. If they have shingles, post-herpetic neuralgia is basically the rash leads to pain associated with it, or central post-stroke pain. Key things here is that we use really low doses for most of these individuals, lots of drug side effects, and more of a concern with older adults, dry mouth. They have trouble pooping, they have trouble peeing, they have dry eyes. Lots of drug interactions, the lowest dose that we possibly need. And again, as they get older, it becomes more of a concern for these individuals. Duloxetine is a drug called Cymbalta. It is an SNRI. It seems to end up helping for nerve pain as well. Again, working for the transmission of pain versus focusing on the site of the pain. We use it for neuropathic pain, for diabetes, and also for fibromyalgia as a first-line treatment. And the number needed to treat, we will need to take between 3 to 7 people for one person to have about 30 to 50% of neuropathy improvement in terms of pain. Neuropathic pain, just to let all of you know, is one of the most difficult pains to treat. Most patients that develop, well, I can just let you know that the data on, if you end up getting shingles as an older adult and you have post-herpetic neuralgia, so after the shingles is cleared, you have that chronic pain associated with it. It's the #1 cause of suicide in the elderly. So it just gives you an idea of how that pain is, and it's just very, very difficult to manage, even with optimal treatment. It's very difficult to get the pain under control. So just to give you an idea of what this is like for pain for these patients. There's 2 drugs. Duloxetine is the main drug. Venlafaxine is Effexor. It has been used for it as well. Again, dosing and side effects I just have here just to have it for your files. Gabapentinoids. Gabapentin, many of you have used, and pregabalin. These are drugs that are used for epilepsy as well, can be used for chronic pain. Like the others, they work for pain transmission. They don't seem to work as well as the older antidepressant drugs, but can be used for patients to help for nerve pain. Again, dosing, key concern with this one is fluid retention, drowsiness, and weight gain for some of these individuals as well. Again, low dose, lowest possible dose to control the pain. And then finally, just to focus on opioids, it's a key question that I get whenever we do something on pain. Not as much of concern in the IDD population as it would be within the general population. But the drugs, this is way back when they came up with the guidelines. For mild to moderate pain, they would use codeine and tramadol. than other drugs. So oxycodone, which is what was in Percocet, which is in OxyContin, morphine, which is what's in MS-Contin, and then hydromorphone, which is in Dilaudid or hydromorph-Contin. Those are used for mild to moderate, more severe pain. This is all kind of changed. They were really pushing away from using opioids for any of our patients. The reason why is we originally thought, A, that these weren't as addictive as they are, that we now know that they are, and that it just doesn't lead to the same amount of pain control. So just to give you an indication, for dental pain, the patients, if you're given Advil versus codeine-based products, so Tylenol 3, the Advil causes it leads to as the same amount of pain control as what you would do as codeine, with less sedation, less constipation, less side effects. So it just gives you an idea that we're just using less and less of these products. One of the things that we're trying to do is, and it is really focusing, and this could be something as your residents, your clients, as they're being discharged from hospital, the shortest amount of time that they need is. So they have surgery and they find that their pain is relatively severe in the first day, but it's going down to the mild to moderate level. The sooner we can get those patients off of those opioids, the better off for their overall outcome. So switching them, moving them from, say, a Percocet, Tylenol number 3 to just extra strength Tylenol or regular strength Tylenol is going to be to their benefit as well, less side effects that are associated with it. Opioids, moderate to severe pain, the pure opioid agonists. So these would be your morphines of the world, your hydromorphones of the world, and your hydromorphones of the world, and oxycodones of the world. Those are usually preferred for efficacy and side effects. So you need to use an opioid, use those. Codeine is a weird drug. I hate codeine in general. Tylenol number 3s, Tylenol number 1s, none of these products are actually great. The reason why they're this way is that codeine is actually the only way it works. It's inactive when you take it orally. It is actually converted to morphine, about 10% of the dose, by an enzyme that's within our liver. The issue is that what we see with it is that some patients will actually all of us have different amounts of this enzyme. Some of us can really convert a lot of codeine to morphine, so we get a lot of morphine, get a lot of pain control, and some of us will get no pain relief from it. We won't convert any of that to morphine. So all we get with codeine is side effects and no pain control that's associated with it. So, and I'm sure you may have seen this with clients where all of a sudden you give them a Tylenol number 3 or Tylenol number 2, and they're just getting no pain relief whatsoever. In that case, we would move them over to a different drug. Morphine is the standard. Morphine is weird because if the patient if they're older and they have kidney damage, we can actually get itch that's associated with it, and a change to something like hydromorphone can help. And then Demerol or meperidine, we just don't use that much anymore. It's a toxic metabolite, just usually used short term. Normally used in the hospital. Most patients are not discharged on it. Side effects that are associated with it, most common one are all stomach related. Nausea can occur. We can give gravel for them, but we usually don't. Sometimes if it's severe, we can try rotating to a different opiate can help. Sedation is usually for the first few days, and it will normally get better after that point. The one itchiness, as I mentioned, is more with morphine. Sometimes an antihistamine can end up helping, or we can change for something, a different drug. The biggest issue is constipation. There's data actually showing that patients, almost everybody, like a good chunk of these individuals will end up having constipation associated with using any type of opioid. Even lowest doses, so even Tylenol number 1, which you can buy over the counter, can cause opioid-induced constipation. What's interesting with this one is it's a lot of times can be more distressing than pain. This is just to give you an idea in, again, neurotypical, but a third of the patients that are taking opioids will say they skip a dose or miss doses to actually have a bowel movement. So what that tells me is they would actually have withdrawal symptoms when they actually skip these doses to actually help to facilitate that component. Fiber, PEG 3350, which is Restorelax, lactulose, which is everybody's favorite. I'm sure you have many people in your residence on it. And opioid receptor antagonists can end up helping for that pain as well. Okay, so that finishes up the presentation. I'll just go through any of the questions that are here. And combination of oral and topical NSAIDs affect daily maximum dosing. This is one of the most common questions that we end up having. So the systemic absorption. So the question, if you see it, is, can I use oral NSAIDs with a topical NSAID? My preference would be to use acetaminophen with a topical NSAID versus using an oral NSAID. The issue is that we do see some absorption of the topical product. The fundamental issue is we don't know how much is going to be absorbed. The more you apply on, the more you rub it in, the larger the area, you can get more absorption. So we just have to be a little bit careful in terms of that overall dosing that's there. I'm not concerned about using Tylenol with that topical NSAID, so it would be that basis. But if you're using the combination of the two, just to be a little bit careful with that in terms of the dosing. I think it's my only question. Is there any other questions that I have? I just want to finish on time. don't see anything coming in. So I want to thank everybody. You're giving up some of your time, and time is always the most precious thing that we end up having. So I really appreciate it. To learn about this one, I can implore you really to try to utilize this one to help to better manage pain. You can make such a huge difference. You know these residents and these clients better than almost anyone. And again, as a parent, as a caregiver for an individual now, you're the one that's going to be there when I'm not there. So I really can't stress enough of how important you are and what difference that you can end up making. On that note, I will turn it over to Alicia.
Thank you. Well said, Michael. So everyone that came today, thank you very much. I'm Alicia. I'm the sales associate, so I take care of everything group home related. So if you guys have any questions about how we can possibly tailor solutions for your residents, go ahead and contact me. I'll send you all my contact information that will come out with the slides on Friday.
Awesome, Alicia. Thank you so much, Michael. That was amazing. So many interesting ways to approach pain and just learning a little bit about the best ways to address the kinds of pains that you might experience or people in your life might experience. So that was really useful. Everyone at Community Living Ontario would like to thank Michael Boivin, registered pharmacist, for presenting this webinar, and our partners, the Health Depot Pharmacy, for hosting this for us. As mentioned in our intro, a follow-up email with a recording of the webinar and the presentation slides will be shared shortly after. If you have any remaining questions or would like to get in touch with the Health Depot Pharmacy by GreenShield, as Alicia said, her contact information will also be in the follow-up email. So once again, thanks again for joining us. Thank you to Michael and Alicia, and enjoy your lunchtime. Take care. We'll see you in another webinar.
Thanks, everyone. Thanks, Ian. Great
Thank
seeing
you,
everyone.
Michael.
Take care.